welcome our speaker, Sir Dr. Naganand KV sir, consultant critical care and cardiac anesthesiologist. Over to you, sir.
Thank you. Thank you, Shavya. Thank you, Raghunath sir. I start my lecture thanking my teachers, Dr. Gurrat Tantri and Dr. Raghunath and Dr. Lakshmikant. Today's topic of discussion is on meningitis and encephalitis. It is intended towards postgraduates. I thank Remedy for giving me an opportunity. Most of a crucial clinical scenario can be answered, not only neurological infection, by thinking in this way, by asking these questions like why this individual in this place has developed this disease at this time. At least it will guide us where we stand in the in diagnosis and an appropriate treatment for it. When it comes to inflammation of the CNS, we have 5 terminologies to understand. Meningitis, encephalitis, which are 2 diffuse pathology of the CNS system. Then we have cerebritis, cerebral abscess, and myelitis. So meningitis is nothing but the inflammation of the meninges. Encephalitis is the inflammation of the brain parenchyma. So it can be a combination of meningitis and encephalitis. Then you will call it as meningoencephalitis. Then coming to cerebritis, cerebritis is a localized inflammation of the brain parenchyma, and you will get a clinical feature and scenario that is related to the particular area of the brain. If this cerebritis gets liquefied and form a wall of necrosis, then you will have a cerebral abscess. Myelitis is nothing but the inflammation of a segment of the spinal cord. You will get a features of spinal cord involvement in the form of flaccid paralysis or sensory loss, like our transverse myelitis. A new terminology has been added, like by ITSA, like when hospital acquired ventriculitis and meningitis. It's a subset of meningitis wherein we get infected ventricles or meningitis by multi-drug resistant infections secondary to our VP shunts or neurosurgical cases. The pathology remains the same, but it is more aggressive, and more aggressive treatment plan has to be done. And a treatment plan will change according to the local antibiogram and local microbiology, what we get. So as you know, meninges are nothing, meningitis is nothing but inflammation of the meninges. So meninges are nothing but a covering of the brain. There are 3 coverings, like on outermost covering is called the dura, the middle covering is the arachnoid, and the innermost covering is the pia mater. Between the arachnoid matter and the pia mater, we have our CSF. CSF is nothing but an extract of the plasma with a very minimal cellularities, less than 5 in a deciliter, 5 cells in a deciliter. If you count this 5 cells, it is 70% lymphocytes, monocytes, very hardly you get a polynuclear cells. And it is around 2/3 of the sugars when compared to the serum glucose. Protein is around 40 grams. And it circulates around this brain and spinal cord. So when we tell meningitis, it is usually the inflammation of the inner 2 layers, that is arachnoid and the pia mater. The inner 2 layers together are called leptomeninges. Leptomeninges is why they are called leptomeninges, because lepto means very delicate. So in meningitis can be synonymous with the leptomeningeal meningitis. So dura is less likely to get inflamed in most of our bacterial meningitis or any other etiology. If that predominates, for example, if the dura mater inflammation predominates, then we have a terminology called plaque meningitis. So the plaque meningitis has its own course. Plaque meningitis is a subacute to chronic type of meningitis, wherein we involve cranial nerves, nerve roots, spinal cords gets constricted. There may be involvement of this coronary sinuses, where we may have a sort of a venous infarct. So it has its own course, which we will not discuss in detail today. We will go into majorly into or leptomeninges, meningitis, nothing but which is involves the inner 2 layers of the parenchyma. So So when it comes to meningitis, you have a acute pyogenic meningitis, which is bacterial. So it's a life-threatening illness, which is it is a fulminating one. We need to act very fast. And there is aseptic meningitis. Aseptic meningitis is nothing but the patient has all the signs of meningitis, except for bacteriologically he is negative, bacteriologically negative. Then we call it as aseptic meningitis. So what are the causes of bacterial meningitis? What we see in adults, the most common cause of bacterial meningitis is still the Streptococcus pneumonia. Why I am telling still? Because even with the advent of pneumococcal vaccination, most of the serotypes get escaped and they do still cause meningitis, especially in a splenic or immunocompromised persons. It accounts to more than 70% right now worldwide meningitis. Earlier, a decade earlier, Streptococcus pneumonia, Neisseria, and our influenza, Haemophilus influenza, is to account for more than 95% of the meningitis. But with the advent of meningococcal vaccination, with the advent of our hip vaccinations and vaccination program, almost the Neisseria meningitis influenza, Haemophilus influenza incidents have come down. Now, more and more hospital-acquired meningitis with more and more deadlier organisms like gram-negative bacteria, aerobic gram-negative bacteria, Pseudomonas, Klebsiella infections, the incidents are rise. We have to one more we have to consider in this slide is the Staphylococcus accounts for less than 5%, particularly in those patients with prosthetic device. And one more is Listeria monocytogenesis, especially in a community acquired with immunocompromised state, in extremes of age, with cellularity, with cellular immunity is less. These are the we have do need to cover for Listeria monocytogenesis. Coming to aseptic meningitis, the most common, more than 50 to 60% of the cases of aseptic meningitis is due to viruses. That too, in viruses, enterovirus accounts for the largest number of meningitis disorders or encephalitis. They do preferably increases the chance of encephalopathy. They do involve parenchyma more viruses. In addition to enterovirus, you can find H1N1, our HIV, our arbovirus, our herpes simplex viruses also are the major causes of viral associated meningitis. Then in bacteria also can produce aseptic meningitis like Mycobacterium tuberculosis, and partially treated meningitis also behave like a aseptic meningitis. Fungi have an acute to subacute to chronic cause of a aseptic meningitis. Parasitemol parasites also causes aseptic meningitis. You also should have a count of non-infectious causes for aseptic meningitis like sarcoidosis, Behçet's disease, our systemic lupus and erythematosus. Drug-induced is also an important cause of non-infectious cause of meningitis. And neoplastics, our lymphomas, leukemias, meningitis are also can cause a leptomeningeal disease that mimics a infectious meningitis also. So how does this organism reach this meninges? So either is a direct inoculation, which is common right these days, where had post trauma or our post surgery or with a shunt, VP shunt or a lumbar puncture can cause a direct inoculation of organism into the CNS system, because the organism has to reach the blood-brain barrier, the CSF blood barrier to reach the CNS system. And also systemic illness, because systemic sepsis, lung infections can reach the blood-brain barrier. That is hematogenous spread of the infection from the systemic to the blood, to the CNS. And there is also direct infection through the peripheral nerves, like our herpes simplex infections, rabies. All this spreads through the peripheral nerve, then they enter the central nervous system. And from the contagious sites are nothing but our nasal and ear. So from where we can, from the sinuses, it can spread into the brain, and it can cause the inflammation of the meninges or the or the brain parenchyma. In this, there is a direct spread, hematogenous spread, and definitely through nerves. Can it spread through lymphatic system? It's a no, because the brain do not have a lymphatic system. Brain have a premature lymphatic system, so direct spread through indirect retrograde spread through lymphatics is very less likely. I'll not go to this time. So when do you suspect a patient's do have a meningitis? Whenever the patient comes with fever, high grade fever, headache, nuchal rigidity, you think of meningitis. So meningism is nothing but fever, headache, nuchal rigidity. The patient may present with photophobia, phonophobia, and there can also be additional or predominantly encephalitis feature. Encephalitis features includes more of parenchymal involvement, that is in the form of altered sensorium, conscious level, seizures, a focal neurological signs can be present, and abnormal reflex. So your clinical presentation may be a mixture of meningism or encephalitis. So if both are there, then you call it as meningoencephalitis. In addition, when you suspect, you can elicit two signs which are pathognomonic of our meningitis. They both the signs, that is Kernig sign and Brudzinski's sign, they test the inflamed stretch on the inflamed meninges. It's a simple test to stretch on to know the inflamed meninges are there or not. In the Kernig sign, you ask the poor chap for after flexing the hip to extend his knee. When you extend his knee, there is a stretch on the meninges, and he will have an excruciating pain in the back. So it is the Kernig sign. In the Brudzinski sign, we'll ask the patient to flex his neck, and in that case, he will automatically flex his hip because knee because he want to relax the hip. So these are the two signs that can be elicited to know whether we have the patient, whether clinical features supports the meningitis. And other pathognomonic feature in case of meningococcal meningitis is a classical petechial rashes. In meningeal features, meningism plus petechial rashes almost in a pandemic area, it almost tells it is a meningococcal meningitis. In that case, either you may not do LP also, you can straight away get a full empirical treatment for it. So once the clinical features suggest you have meningitis, what next you have to do? That's the question comes. So what really you have to do is do a LP. Is the patient is safe for doing an LP? Is the next consideration. In LP, what do you ask? In lumbar puncture, what do you ask for? In a lumbar puncture, you can ask for an opening pressure, microscopic and culture and sensitivity, protein and glucose, which is paired with the serum. At the same time, simultaneously, you have to take blood samples from the patient. You can ask for a lactates, and if prayer and antibiotics is not CSF lactates. CSF lactate is quite newer development, very new. The cutoff level is kept at 4 millimoles, but CSF lactate can also rise with seizures, with blood in the brain. So it has to be a marker. But if you are not given antibiotic, it is also considered an important marker. Then you have procalcitonin. You especially a CSF to procalcitonin ratio in a bacterial meningitis is more. So early CSF rise of procalcitonin occurs. So you can also have a procalcitonin as a marker, and you can do pneumococcal and meningococcal PCRs and viral PCRs like enterovirus. You can have herpes simplex virus or Bacillus virus PCR. You can do to get into a diagnosis of the organism, which is quite essential. Mm, so, in a safe patient, you directly go with a lumbar puncture. Once you take the lumbar puncture, you ask for an empirical antibiotic therapy, plus or minus an antiviral, and an adjuvant called dexamethasone. But in some unsafe patients, we call unsafe patients is the patients which are unsafe to get an LP done. Which are such patients? Which are the patients who have an recent altered sensorium, a new onset seizures, and papilledema, a focal neurological deficit, and especially immunocompromised who are likely to have a mass occupying lesions in the brain, these are all unsafe patients. In this patient, we avoid doing an LP directly. We will ask for a CT scan, but asking for CT scan should not delay the treatment. We should take a blood culture, give an empirical therapy, then go for a CT scan. Then, if the CT scan doesn't show any of this, either rise of ICP or space occupied lesion, then we go for an LP. And after LP, definitely we have to continue the empirical therapy till we get our investigation CSF analysis. So it's always a trouble reading a CSF reports analysis report. You take the sample of CSF, and ideally we have to take the sample immediately. Better to analyze it immediately, because to assess as the time passes, the cells get destructed, And the proteins may also vary because of the cell destruction. There may be rise in the proteins, which may give an error related reports. Ideally, for PCR, you can store the samples, but for a general regular routine analysis, it's better to immediately get an analysis done. Ideally, we take two samples, an EDTA samples, which keeps the cell intact for a little prolonged period of time, but it may rise some amount of protein level, and we take a plain sample in which we definitely look for the cells and proteins. So that's how we do. We never usually don't store CSF, and if only for PCR, we may store the PCR overnight, so we can because PCR doesn't require immediate reporting. But how to address when you have got a CSF analysis, remember the two things. The two things is always rise, proteins and our opening pressure is always rise. And depending upon the organism, the level of the proteins also increases. For protein, for virus, it is a slight rise. From bacteria, it's a still more rise. Fungi, it is still more. For tuberculosis, the highest rise in the proteins that you have to consider. So, the larger the size of the organism, the larger the protein. It is just an easy way to remember. Larger the size of the protein, the more they eat sugars. And that if you just to remember this. So, in a bacterial, you have a high opening pressure. Definitely, if you get a cell count, you will have a polymorphic cells. If polymorphic cells are there in the CSF, then definitely it is a bacterial meningitis. It is still proven by more protein and less sugar. Then, if you have a lymphocyte, then you have two choice: one viral and other one is bacterial. The viral has the normal sugars. Tuberculosis. Tuberculosis has a very high sugar. So this is how you have to read the CSF analysis when you come. Can go through this slide. Then, in addition to the CSF SAM analysis, we may ask for routine blood test, that is to understand whether the patient is sepsis or not, whether other organs are involved or not, like our infective mark like CRP, procalcitonin. You will definitely need to take a glucose to pair it with the CSF. You can ask for blood cultures, meningococcal and pneumococcal PCRs. You can know the immune status of the patient, whether it's immunologically deficit or in the form of HIV, or he has any other organ he has received chemotherapy or in that way. And you can also consider pneumococcal antigen, urinary pneumococcal antigen, it is if it is available. And still sometimes etiology will have a mixed picture in your CSF. Etiology is your lab reports may not help you out. Then you can divide it is whether you have a bacterial suspect in the form of you can get a 16S rRNA PCR on CSF. If you have a viral suspect, you can ask for a throat swab or a stool sample for Enterococcus PCR. Further, we can guide the CSF PCR along this line whether we are a viral suspect in this case. And also in Indian scenario, we always have to suspect of tubercular meningitis, especially in HIV or immunocompromised. You have to think about cryptococcal meningitis. So you have received your CSF and you have taken a lumbar puncture and you have sent it for analysis. You can't wait for the analysis to come. You definitely have to go for an empirical therapy. In most of the cases, the acute meningitis, bacterial or non-bacterial meningitis, is to be considered life-threatening. So you need to give an empirical therapy, and an empirical therapy includes an antibiotics. If the encephalopathy is more, we have to add up with an antiviral. Especially, we have to consider our herpes simplex virus infection. We need to add acyclovir. Then you have to add one adjuvant, dexamethasone, which I talk in later. So, which is an ideal antibiotics in a meningitis scenario? Why you have to worry about an antibiotic? And you usually know that we give a large dose, higher dose of antibiotics in case of meningitis. Why you need to give meningitis? So, an ideal antibiotics for meningitis is one is which achieves a very high concentration in the CSF, because the antibiotics has to cross through two barriers. One is blood-brain barrier, then the blood CSF barrier, and enters into the and it should attain a sustained concentration for its bactericidal effect. They say more than 10 times the mic value it has to achieve in the CSF. Do CSF behave like other compartments of the body? No, the studies have shown that the CSF itself doesn't behave like a one compartment. The concentration of achieved in the lumbar region is more when compared to the ventricle system by IV administration of a drug. And lumbar has a reasonably less uptake of drugs. It has a reasonably high half life of antibiotics when compared to the ventricles and cisterns. So whatever the drugs what we are using should have achieved higher concentration. So we give a higher dose of a drug, and it should have a bactericidal effect. Bacteriostatica has a less chance because it should be act fast and it should kill the bacteria, and it should be against the common pathogens. Look, a common pathogen is we don't know the CSF report. It's an empirical therapy. Then we should definitely target the age group which is involved, whether it is the organism most likely in this age group, whether it is an hospital acquired infection. Then definitely you should in the antibiotic what we are giving should target such organisms. And if there is less of meningeal irritation or early meningism, then definitely a moderate lipophilic with less protein bound will help to achieve a concentration in the brain, because blood-brain barrier is a single cell with the two lipid layers which attracts the lipophilic antibiotics and shifts this into the CSF. Once the meninges gets inflamed, it is a more and more hydrophilic antibiotics that attains their role in the that attains as concentration in the CSF. So choosing an antibiotic. Choosing an antibiotic plays an important role in all the values. Whatever we see here, this all the factors plays an important role in choosing an antibiotics. Look, the antibiotics has to enter the blood-brain barrier or blood CSF barrier. Then it depends upon the meninges itself. If it is inflamed or not. If it is hydrophilic, then there is more penetration of antibiotics. Whether there is a neurosurgery in insult or not, because it may breach the blood-brain barrier. Whether the properties of antibiotic is whether lipophilic or hydrophilic, upon the molecular weight of the antibiotics, plasma protein binding nature of the antibiotics plays an important role in achieving the concentration of antibiotics in the CSF. And even the bacterial species, they say, like Streptococcus pneumoniae, which is the most common, it is less antigenic when it is intact, cells are intact. So it has a very low penetration. But once it is released, once it's broken down by antibiotics, it releases a lot of antigens, and then it makes the then it makes the meninges inflamed, and it allows more and more antibiotics to enter the cells. And the Listeria sepsis have a higher penetration of antibiotics. That again, it depends upon the inflammation of the meninges. If once the concentration is reached in the CSF, how long it's going to stay in the time value. It also depends upon the variation in the anatomy, age, disease process, lipophilic or hydrophilic nature of the antibiotics, and the local compartment flow also matters a lot. And the clearance of the antibody from the CSF compartment depends, because it's a single one directional absorption of the CSF. That also matters, that also determines the flow of the CSF. So it also depends upon the circadian rhythm, meningeal inflammation, and the disease. And antibiotics in properties also plays a role in the clearance of the antibody. So to choose an antibiotics, ideally we need to consider all these factors. So most of the time, there is not a criteria as in turf level is in blood we can't achieve, may not mimic the same in the CSF. So ideally, what are the guidelines they say depends upon the age group and which most likely organism organism most likely cause of the meningitis. Like if the patient is more than 18 years of age, he is immunocompetent patient, he is most likely to be Streptococcus pneumonia, Neisseria meningitis, very less likely now of H influenzas. The first line remains a ceftriaxone, that is third generation cephalosporin. We give at 2 grams 8th hourly dose. In addition, we add vancomycin. We add vancomycin not to cover a staph or I think just to there are subset of, especially in our tropical area where there is a resistance to ceftriaxone. So to cover that we add vancomycin, 15 to 10 to 15 milligrams 12th hourly we give, and then we add an adjuvant called dexamethasone. If the patient is immunosuppressed, HIV or any malignancies or chemotherapy patients, or pregnant women, or more than 50 years of age, alcoholism, then definitely in extremes of ages, definitely we have to cover the patient for Listeria monocytogenesis. In this for community acquired, I'm telling. So then we have to add ampicillin, that is 2 gram IV 4th hourly. In addition to ceftriaxone, vancomycin, dexamethasone, we are going to add ampicillin. If the patient is encephalopathic, the encephalopathic features are more like altered sensorium, seizures, in addition to meningism, then we have to suspect a viral etiology also. Then it is very necessary to add acyclovir, which is renal adjusted dose of 10 milligram per kg, IV and 8th hourly. If any of the allergies this for this antibiotic, like ceftriaxone, if there is an allergy, you should have an alternative antibiotics. If it is life-threatening, definitely we have to go for an azithromycin 2 gram IV 6th hourly. If it is less likely, you can use meropenem 2 gram. Then there should be a substitute for even for ampicillin in the form of trimethoprim and sulfametazole ointments, antibiotics. So this has to be any allergy. If it is life-threatening penicillin allergy or a non-life-threatening penicillin allergy, non-life-threatening, you can use meropenem. You can substitute with meropenem. Then comes the basilar skull fracture induced associated meningitis. In this case, you remember that more and more commensals around the or in the nasal areas, they take a heparin in the form of group A streptococci, atelectasis, streptococcus pneumonia, H influenza. Again, the treatment remains the same: ceftriaxone, vancomycin, plus or minus viral cover, and dexamethasone as an adjuvant. In penetrating injury, now they shifts into a fourth generation cephalosporins. Penetrating injuries, they especially in a hospital setup, getting treated in ICU, you are more likely to get staph aureus, Coagulus negative staphylococci, aerobic gram-negative bacillus like Pseudomonas klebsiella, and your antibiotic profile changes from cefepime, like 2 gram IV TID, and vancomycin 15 to 20 milligrams per kg in divided 12th hourly, because they are definitely multi-drug resistance, and you may add, depending upon your local antibiotic, you can add ceftazidime, or you can consider polymyxins also. If there is allergy, again the same, the meropenem 2 gram IV 8th hourly is given as a substitute. If it's life-threatening, then we use azithromycin. And post neurosurgery, definitely we are going to get the local microbiologic flora, which are multi-drug resistance, and most likely to be a Pseudomonas, anaerobic gram-negative bacillus, la Staph aureus, or Coagulus negative, and the treatment remains the same: cefepime, fourth-generation cephalosporins, vancomycin. You can substitute meropenem or azithromycin in case of allergy. Presence of a CS stunt, like a VP shunt or something. Again, local microbiological flora. We are here given again cefepime, vancomycin, ceftazidime can be given, polymyxin, in addition to the removal of the stunts, which is become the priority. Meropenem as a substitute in case of a penicillin allergy, or azithromycin in a life-threatening allergies. Just go through this. You can get it in many other articles where it varies the what is ideal antibiotics for each organism, what is the alternative. I'll not read in detail. So once you have started an empirical therapy, how to go ahead with the duration of the antibiotics. If you get an LP culture which is bacteriologically negative after 48 hours, and or there is no mononuclear cells, then definitely you can stop antibiotics. You can think of continuing antiviral. If the PCR is also negative, you can stop antiviral also. You have to look for other autoimmune disease or drug-related meningitis. In case of a streptococcus pneumonia, you definitely have to continue it for 10 to 14 days. Meningitis, Neisseria meningis 7 days. Listeria 21 days, and influenza 7 days is according to the ITSA guidelines, and gram negative for 21 days. Now comes why do we need to give a dexamethasone in a case of patients who has been treated empirically for meningitis? So dexamethasone, if you have to give, why you have to give? Dexamethasone is anti-inflammatory. Definitely, it reduces the inflammation of the meninges. Recent guidelines says use it only in case of a suspected pneumococcal meninges in a community-acquired pneumonia. Look, in only in a community-acquired pneumonias. Why? Because this Streptococcus pneumonia, once they are broken down the antibiotic, there is a rush of these chemical mediators, inflammatory mediators, which increase the mortality, which injures causes more of inflammation of the meningitis. So we give dexamethasone. Why it has to given prior to the or 15 to 20 minutes prior to the or concomitant to the first dose of antibiotics? Because just it so that the anti-inflammatory action is in situ before a lysis of the cell occurs. So what's the dosage you give in for dexamethasone? It's around 0.15 milligram per kg, 6 hourly for 2 to 4 days, preferably for 4 days. Does the administration, you don't need to administer dexamethasone if already the patient has received antibiotics. Um, so recent guidelines say should be given for streptococcus pneumonia. If your CSF you find diplococci or your PCR shows streptococcus pneumonia or cultures has grown streptococcus pneumonia, we are going to continue dexamethasone as an anti-inflammatory measures. And also remember, dexamethasone reduces the inflammation of the meningitis, which will alter the concentration of many drugs that is used, especially vancomycin. Turf level of or CSF level of the vancomycin reduces. So that has to also be kept in mind. You can't use dexamethasone in a already septic patient or hematogenous spread of infection is there. There is or a patient or incompetent patients. Definitely, you can't use a dexamethasone. It may flare up other opportunistic infections. You do use it in a TB meningitis. There are two incidents for using TB in TBs. One is TB meningitis, and other one is TB abdomen because there is lot of fibrosis. So you do use corticosteroids in such cases. This is regarding the use of dexamethasone in meningitis. Then, as you know, more and more stunt-related, EVD-related infection are seen. The concept uh, whether whether we are whether we can give directly the antibiotics into the intrathecal or intraventricular system has been arised. Because we can achieve a higher concentration and more dependent concentration, so that can have bactericidal effect and more effective. We have recently been using intrathecal if there is an EVD. Again, intrathecal administration is an off-label topic for IDCA guidelines. Recent 2017 guidelines has told for Acinetobacter baumannii you can use polymyxins or colistin. Uh, so it should be considered for an healthcare associated ventriculitis and meningitis in which the patient is poorly responding to systemic antimicrobial therapy. Again, there is a variation. If you are using it to a lumbar puncture, the concentration achieved of the drug is varied. Preferably, it is an intraventricular injection. We take under aseptic care, we take the desired concentration of the antibiotics. We open the EVD system and keep inject the drug and again close it. Wait for around 15 to 20 minutes to act. This is how we do. But evidence does not support in prophylactic intrathecal administration of antibiotics. Even when the patient is on EVD, you no need to give there is no evidence to give a prophylactic antibiotics to prevent meningitis or ventriculitis. Uh, Remember, starting an uh, intrathecal antimicrobial therapy depends upon the susceptibility and also the lack of anti-infective drugs reaching an adequate concentration in the CSF when given IV fluid. That has to be clear. It should also have a very low toxicity to the and no low neurotoxic and low side effect to the host. So, what are the side effects of using an intrathecal administration? Intrathecal administration, it is maybe epileptogenic or seizure-inducing drugs may be used. It may cause mimic a aseptic meningitis, a chemical meningitis can produce, which will mimic worsening of our ongoing meningitis. And whenever you remove the closed system of EVD, you are going to give a chance for the other polymicrobial to enter the system. So these are the side effects of So these are this has to be considered when you are using a intrathecal administration of the our antimicrobials. So these are the use. We commonly use the colistin. We have used colistin commonly. We have used colistin as 5 milligrams BD dose. It's around 10 milligram. They say definitely there is meningeal irritation. There is epileptogenic chances, but we have used polymyxin also. Daptomycin is becoming more and more used because they achieve higher concentration and less toxicity when compared to other like vancomycin also. It has been used in direct instillation also. Glycopeptides, and we are not have more data on antifungal, but there are case studies where they have used direct instillation also. Even aminoglycoside has been used, little more data when compared to uh, other other agents. So briefly to talk on encephalitis as a part of meningitis is whenever you have more of an encephalitis features, definitely you have to treat patient with acyclovir, suspecting a herpes virus. If you have done an MRI, if it is showing temporal enhancement, definitely you give an acyclovir. Because acyclovir, if you are not given acyclovir, it has a very high rate of mortality, more than 70% rate of mortality, they say. So definitely you need to give acyclovir in case of encephalitis along with the empirical therapy of and antimicrobials and dexamethasone. Acyclovir is given at 10 milligram per kg body weight, but it has to be altered according to the renal status. This is summarized. So you get a patient which you are suspected to have uh, uh, in which you are suspected to have a meningitis. There is meningitis signs, then definitely you have to stabilize the patient first for air breathing circulation. Then you have to ask whether the patient is safe or unsafe for LP puncture. Then, if it is safe, do go ahead with the LP puncture. Then administer an empirical antibiotic therapy, plus or minus antiviral or a dexamethasone. If it is unsafe, then you have to go for a CT scan. Then perform a lumbar puncture. Then you start your empirical therapy. One more thing is, in case of rickets cell suspected, you can also use doxycycline and along with this. Uh, Once you get a cerebral CSF analysis, whether it is bacterial, viral, or fungal TB, you get to know. Then you have to you get a targeted therapy. And still more, if you get an organism, like if you get Streptococcus pneumonia or MRSA, you can start with continue vancomycin. Meningitis, again, ceftriaxone, vaccines. Listeria monocytogenesis, ampicillin, Enterococcus, gentamicin, E. coli, ceftriaxone. Pseudomonas cephipam, ceftazidime, polymyxins, rickets cell doxycycline. So this is how we have to target. How this approach to meningitis. Um, you need to give post prophylaxis, especially in case of H influenza and Neisseria meningitis. Adult we use with rifampicin, especially if there is exposure is less than 6 hours to 48 hours. If it is more than for 6 days, you need not give a prophylaxis, chemoprophylaxis. It is given in the form of rifampin, ceftriaxone, and also ciprofloxacin is given for pregnant women. Ceftriaxone. Thank you.
Thank you so much, Dr. Naganand. It was an excellent presentation.
Thank you, sir. Thank you.
Each slide give a lot of message
Yes, sir.
regarding meningitis as well as encephalitis. It is a very big topic, but you managed to cover within 30 minutes, 35
Thank you.
minutes.
Thank you, sir. Thank you.
Any question from students or audience, please, you can ask question directly or put the question in chat box also. My question, Dr. Naganand, regarding steroid. Recent Cochrane review found that steroid has lead to very small reduction in mortality in pneumococcal meningitis.
Yes, sir.
What is your view? In spite of all guidelines mentioned about steroids, in all guidelines there is steroid dose is there, 10 mg hourly, but that Cochrane have shown that there is a less reduction.
Less reduction. Especially the more the guidelines have come. Recent guidelines are almost differing use of dexamethasone, sir. But it is especially in community acquired pneumonias, we may not be able to know whether a meningitis is inflamed or not. There's a recent article what we read through what neurologists also told to get an MRI done. See a flare or something which is whether it's showing meningeal enhancement or not. In that case, if there is less of meningeal enhancement, then if your patient is not doing good even with a good dosage of antibiotics, then definitely your dexamethasone can be reduced or inflammation is less. That is one of the thing. Even for the intrathecal administration, also the MRI with the flare they have started using. If there is less of meningitis, you may consider a direct intrathecal administration of the antibiotics. This is one way to adjust the whether need or not of dexamethasone. Definitely, dexamethasone may not be helpful in case of a hematogenous spread of inflammation. And recent ITSA one also says it is a controversial topic according to most of the guidelines they say because earlier it was used as a H influenza used to cause my ear loss or hearing loss and mortality was more. They used to use as an empirical therapy. Right now, I think as few doses can be given, but lack of evidence for the dexamethasone. As the day more and more studies are done, more Cochrane studies are done, lack of evidence is going for towards the dexamethasone, sir.
And also, message was very clear. Brain imaging is not required.
No, no, sir.
Majority of the cases there is a maybe delay. If you are very particular, you can go ahead with the antibiotic or antiviral. Then
Antiviral.
so there should not
Yes, sir.
be delay for
Delay.
stage.
If you are not able to do a CSF sample, take the blood cultures, give an empirical therapy. Then then you can go for imaging. Then you can do an LP also, sir. But the time is precious, especially in a bacterial meningitis, where you need to achieve a good side effect of antibiotics in the
Okay.
CSF, sir.
While telling the etiology of the meningitis, I think viral predominates, especially
Hmm.
enterovirus predominates, right?
Yes,
In
yes,
your
sir.
list, I think it was the bacterial was the first list. I think more of viral.
The
That
most
is
common cause of meningitis is viral meningitis, sir. But as a bacteria, and I divided it into bacteria and aseptic meningitis, sir.
okay. Uh, Hello.
Yes, yes, please.
Okay. And regarding that, then one more thing. When there is a doubt in the bacteria versus virus, CSF polymer chain reaction will
Hmm.
rapidly
Yes.
detect virus versus bacteria and maybe a gold standard. That was a
Gold.
very good message actually. Most
Yes,
of the
sir.
time, your patient will come with already having received antibiotics.
Yes,
So
sir.
go for
Mm.
CSF, PCR.
Yes, sir. Most of the tertiary, when we receive a patient in a tertiary center, they have already received antibiotics. So better go for a meningoencephalitis PCR panel and get and easy to get a report earlier also. Within 6 hours we get the report. Most of the time, 2 hours when we can target our therapy very well, sir. And coverage of antibiotics also helps us a lot in what multi-drug resistance what we are
If
getting.
you do PCR in other sites, there may be a contaminant or colonization that may be
Colonization,
there. But here,
but
I think it is straight away tells infection because that
infection.
otherwise may not be possible in the, especially viral. We know the etiology easily. And
Yes, sir.
already received antibiotics, and we can go for PCR. I think it is a very good message what you got from your talk. Um, any other question from audience regarding procalcitonin? You are talking about procalcitonin. That can repeat that
Sir,
procalcitonin.
CSF procalcitonin, sir.
Yes.
CSF procalcitonin, is it a marker, early marker of bacterial meningitis? That was the question to be asked, sir. There are more and more articles that coming on.
Okay.
They have compared isolated procalcitonin in CSF. A rise in CSF can happen with an inflammation, bacterial related inflammation. But when it is correlated along with the blood procalcitonin, the ratio between the CSF procalcitonin to procalcitonin, if it is high, the CSF procalcitonin is predominantly high, then definitely you can consider it as a bacterial meningitis. You can early initiate a broader spectrum antibiotics in that case. This is what one of the studies that shows, sir.
CSF to blood procalcitonin ratio, right?
Procalcitonin ratio, sir.
Same thing. CSF blood glucose ratio less than 0.6.
0.6.
Yeah, it is
All the ratio between
meningitis.
this. If the ratios are more, then definitely we are more in an inflammatory markers, in a more meningeal supporting of antibodies will go.
So when there is doubt, is there bacteria, virus? You can
Virus
go for ratios.
ratios,
CSF blood glucose ratio, CSF
ratios,
blood protein
procalcitonin
ratio, procalcit ratio.
ratios, sir.
That's
Ratios.
also very good message actually.
Sir, thank you.
Thank you, Dr. Naganan. If any,
Thank you, sir.
I think most of them
Yes.
are college recommended students are there here.
Yes, sir.
Anybody want to ask questions? Please welcome, or you can
Let- Let
contact.
them write us on Remedy International, sir. We'll definitely address this thing, sir.
Okay.
All the queries, whatever it is.
Thank you, Doctor. In spite of India Pakistan World Cup match,
Yes, sir.
doing this
Yes,
one.
sir. Thank you, everyone, sir.
The audience is there. Thank you so much. Thank you.
Thank you, Raghunath, sir. Thank you, sir. Thank you. Thanks a lot,
Thank you,
sir.
Shama.
Thank you, sir. Thank you
Thank you,
so
Shama.
much.
Thank you.
Thank you, sir.
Thank you. Thank you.